am really excited to talk to you today about 2 scans done collectively by the good doctors Whitmore, Wong, Tomlinson, Eddy, Todd, and Mays. We're going to talk about Tetralogy of Fallot today. This congenital heart condition is most often repaired in infancy or childhood here in the U.S. Today we have 2 examples of adults with unrepaired Tetralogy of Fallot seen in the adult ED. The word tetralogy is used because there are 4 related abnormalities associated with this condition: a ventricular septal defect, pulmonic stenosis, an overriding aorta, and right ventricular hypertrophy. In these first images, you can see that in the parasternal long axis view of the heart, there is a readily visible ventricular septal defect, with an aortic root that clearly sits right over the defect. Can't see that? That's okay. Here, we'll put some color on it to make it a little clearer. Now you can see the flow through what should be an intact septum. Here it is on the other patient, with an even more clearly visible ventricular septal defect that is under an overriding aortic root. Here's what it should actually look like, with the aorta coming entirely under the septum in the left ventricular outflow tract. Tetralogy of Fallot is one of the classic cyanotic heart lesions in babies. Patients have some degree of mixing at the level of the VSD, which you can see here in the apical views, causing decreased oxygen saturations. They also classically have hypercyanotic spells, sometimes called TET spells, precipitated by either decreased systemic venous return, tachycardia, dehydration, waking from sleep, or increased pulmonary vascular resistance, crying, pooping. Once they enter the cycle of increased right-to-left shunting that this causes, it becomes worse and worse until you can break the cycle by relaxing the infundibulum or increasing systemic venous return. Measures that do these include calming the child, placing in a knee chest position, giving morphine, or even using direct pressure over the aorta. Over time with episodes, increased flow and pressure in the right heart worsens right ventricular hypertrophy and pulmonary hypertension. Here in the parasternal short views, you can see thickened bilateral ventricles and a flattened septum from increased right heart pressures. Here in the views of the IVC, you can see that the IVC is quite full with little respiratory variation, which is unsurprising given expected right heart pressures. To see the long-term consequences of unrepaired tetralogy of Fallot, we will look back at the first patient whose clips we viewed. Here in the apical 4-chamber views on this patient, you can see the VSD, and here you can see flow from right to left. This patient has developed Eisenmenger's syndrome. In this, the previous left-to-right shunt has now become a right-to-left shunt, secondary to elevated pulmonary artery pressures and associated pulmonary vascular disease. This happens in lesions such as large septal defect, as in Tetralogy of Fallot, that cause a high pulmonary pressure and/or high pulmonary flow states. Once the persistent right-to-left shunt has developed, the pulmonary hypertension is generally irreversible, and the cardiac lesion is likely to be considered inoperable. Once Eisenmenger's has developed, the patient has very high risk for further complications. In this case, the patient was noted to have a small pericardial effusion and a pleural effusion associated with consolidation. In this clip of lung, you can see pleural effusion and consolidated lung with air bronchograms.